A 17-year-old girl renders a history of progressive cyanosis, hemoptysis, and episodes of syncope. On examination, he has a surprisingly prominent left precordium and an ejection murmur in the 2D left intercostal space. What is the presenting diagnosis? 1. Atrial septal defect, ASD, with aortic regurgitation. 2. ASD with aortic stenosis. 3. ASD with mitral stenosis. 4. ASD with pulmonary hypertension. 5. Uncomplicated ASD. Answer: ASD with pulmonary hypertension. Update. Atrial septal defect, ASD, is one of the common congenital heart diseases with a prevalence of 1.6 per 1,000 live births and accounting for 8 to 10% of all congenital heart defects, CHD. Pulmonary arterial hypertension, PAH. Defined as pulmonary arterial systolic pressures, PASP, greater than or equal to 40 mm of mercury, has been noted in 6% to 35% of patients with secundum ASD. Moderate to severe pulmonary hypertension, PH, in ASD is seen in 9 to 22% cases. PH in unoperated patients with ASD has been associated with functional limitations. Atrial tachyarrhythmias, heart failure and increased mortality. Preoperative PH remains predictive of mortality, heart failure, and arrhythmias even after closure of the ASD. PH in the setting of an ASD can be secondary to various etiologies. Post-capillary PH can be due to elevated left ventricular, LV, and diastolic pressure as seen in elderly patients with hypertension. Ischemic heart disease, diabetes mellitus and chronic kidney disease or due to mitral valve disease as in Ludenbacher syndrome. Precapillary PH, PAH, can be secondary to a large shunt or in some cases may be disproportionate to the magnitude of shunt. At one end of the spectrum are patients with reversible PAH who will clearly benefit from closure of the shunt. At the other end are those with irreversible PAH with shunt reversal, Eisenmengerization, in whom closure of ASD will be counterproductive and therefore will need to be managed medically. The challenge is to precisely identify the subset of ASD patients with reversible PAH who will benefit with shunt closure. One must consider the most common pathology in the light of clinical findings. It is not going that this man has an ASD and also has left-sided heart failure. Otherwise his signs and symptoms would mirror this scenario. His outstanding left precordium suggests that the proper ventricle is dilated and that he has improved right-sided pressures with expanded turbulent waft via the pulmonary valve. He is young. So we suppose without delay about congenital ailments and their complications. It is vital to comprehend that hemodynamically tremendous ASDs can lead to pulmonary hypertension over time. Atrial septal defect, ASD, with aortic regurgitation is incorrect. The murmur associated with aortic regurgitation is diastolic. And this would be an odd affiliation with an ASD. ASD with aortic stenosis is incorrect. Remember, aortic stenosis would be located in the 2D intercostal space on the proper top sternal edge.